My experience as a regulator was that the hardest decisions you had to face were always the ones where the results were borderline. It's borderline for one of three reasons. Either the treatment effect was not as large as you were hoping for, or the variance is larger than you were hoping for. And there's a kind of nuance on those two, that you were right on the relative but wrong on the absolute scale. And by that I mean you thought you'd see a 40% improvement on your active and 20% on control. And you actually saw a 30% improvement on active and 15% on control. So you always have a relative risk of 2, you always double your chances of a good event, but you were wrong on the absolute scale, and so you'll end up borderline. My experience is that almost all clinical trials that end up at the borderline are ones where the treatment effect is not as large as you had hoped it to be at the start. And if you have actually designed your clinical trial with the minimally clinically important difference, then under those circumstances, the point estimate, the effect that you will have out of that trial, will definitionally be smaller than the minimally clinically important difference. And that is when all of the problems start, because you have something that is statistically significant but possibly not clinically relevant. People will ask questions about estimands, estimation, missing data, whether one patient included makes or breaks the trial, subgroup analyses if you can find a particular patient population where it seems to work better than others. So those borderline decisions are all really the hardest ones, but you still have to make an absolute decision to stop or carry on.